Great. I think everyone is in. I'll have one more group. There we go. Welcome, everybody. Welcome to the third of Dr. Evan Steinke's lower extremity webinar series. Tonight, as you know, is all about the knee. For those of you new to the AST webinars, my name is Renee Westmacott, and I will be your co-host for the evening. Know that I'm always standing by for any questions that might come up. Feel free to ask them in the, what was that called? In the group chat. Is that right, Dr. Evan?
Yeah, you can just type into the chat bar, and just when you do that, just make sure it says everyone so that we can also read it.
Perfect. Thank you. And if the questions are relevant, I will interrupt. If not, we can review them at the end of the webinar. A little bit about Dr. Steinke for those of you that don't know. Dr. Evan Steinke joined the AST Westman chiropractic team earlier this year. His wealth of knowledge is always very much appreciated. His upper extremity and lower extremity webinar series have been hugely popular, and you can find any previously recorded webinars on Active Sports Therapy's YouTube channel. We'll send a link in a follow-up email. In his practice, Dr. Evan puts each individual patient's needs first, working closely with the patient to maintain a strong lifelong relationship and assist them to live their best lives. Dr. Evan Steinke is taking new patients at AST Westman, and all the contact information will be available at the end of the lecture. And that is all from me. Please join me in welcoming Dr. Evan Steinke. Good evening.
Perfect. Thank you, Renee. Thank you for the beautiful introduction as always. So this is going to be part 3, guys. This is for the lower extremity series. Don't worry if you haven't caught the other ones. They're pretty independent. And like she said, if you want to go back and watch the other ones, which I will mention a little bit in here, there will be a link to the YouTube at the end of this lecture as well. So I'm just going to get started here. So just a quick overview. We're going to run over the general anatomy of the knee. So we're going to do it in phases just like before. We're going to start with the bones. We're going to go to ligaments. We'll talk a little bit about the muscle and the motion of the knee. And then we'll talk about common injuries along the way that happen to each one of those layers. And then we'll discuss a bit about the treatment and management. Now, particularly, I've put in a fair amount of information in this slide show about ligament repair. The knee is just full of ligaments, but really this knowledge can just be transferred to any ligament injury throughout the body. So feel free to use that in any way you need. And then also we'll talk a little bit about home care. I've developed some stretches that would be helpful, talk a little bit about prevention as well. And then of course, we'll open the floor to questions at the end, but do feel free to just type them as they come up. My qualifications are that I have a bachelor's of science in human biology, and I'm also a doctor of chiropractic. I got both from the University of Western States in Portland, Oregon. So with anatomy, we'll be covering all the different layers, but I think it's most helpful to just kind of get a global sense of the knee. And the first layer that we really want to focus on is the bones. So some of these will be pretty familiar. The femur, that's the upper thigh bone that we can see here. It's pretty well known, but it's also the strongest and the longest bone in the human body. So it's remarkably useful for transferring loads from the upper body to our lower extremities. And it passes most of that force off onto the tibia. So this is the lower part of our leg. And what you'll see is that actually, instead of one giant smooth surface, the femur basically splits into 2 knuckle-like structures. So it passes that load on through these 2 pathways. And what this allows the body to do is have ligaments inside the joint, like right in the middle, which you can visualize here, which really adds stability to the knee joint. The floating joint or the floating bone up here is the patella, also known as the kneecap. This is pretty important for transferring loads from the upper leg into the lower leg, particularly the quads. So if we look on the other side of the image here, you can see that there's some tendons hanging off of it. So this is how the quads pass the load into the lower leg. And then lastly, we have the fibula, which isn't really part of the knee joint. I'm just mentioning it here because it's close association with it. This joint is really a fibrous connection, so we wouldn't expect it to move a lot. In fact, if it is moving, you probably have an issue and probably pain associated with it. So that would be something that we could always look into if you are experiencing that. But you can see in the image, right, it's just connected right by connective tissue directly into the tibia, and it really shouldn't be moving, and it doesn't actually articulate with the knee in any way. So I did want to run through what x-rays of the knee look like, because I'm going to pull up a couple x-rays. So this is a healthy individual and an adult. In what I wanted to show you here is like how we would go about reading them, right? So the first thing we want to look at is kind of the outline of the bone. So if we follow that around, the first thing we notice is there's no jagged edges. Everything's nice and smooth and very clear, right? We can see well-defined lines throughout. So as that femur comes down, you can even see the two separate knuckles that I was talking about. You can see each one is well-defined. Same with the kneecap out here, right? Nice smooth lines, consistent throughout. And then the tibia as well, right? Particularly in the front, which is something that's going to come up later in the lecture, is this is nice and smooth. In a healthy individual, it should be. And then if we look over on the right side, this is looking straight from the front. So it's pretty faint, but if you look in there, you can see the kneecap sitting right on top. And then the other thing we want to look for is that there's a nice even joint space, right? We can see that translucent gap right between, and that should be there. That's healthy to have that, okay? So if we move to looking at the joint surface, what we can't see on an x-ray is this clear stuff in between. When the x-ray goes through, this doesn't show up at all, but this is the meniscus. It's a piece of cartilage that's C-shaped. We have two of them in each of our knee, and they provide that pad for the knuckles to sit on, okay? And when we jump up and down, this is also going to act as like a shock absorber. So it's multifunctional, and not only is it helping with shock absorption, but it also helps kind of center that knee on the joint as you pivot or as you move that hinge-like joint, right? So if I just go back, remember that joint gap I was talking about, this is actually filled in with the meniscus, right? So that's what's providing that nice joint space, okay? So let's talk about the knee movement. When we think about a knee, we really think of it only as bending, and that's because it's a hinge joint. It should only go forwards and backwards, okay? So if we think about the simplest version of a hinge joint, it's this. It only has one range of motion, kind of forwards and backwards in this rotational movement, and that's what we would expect of a knee. We will talk about some situations where this isn't occurring, and that's usually when things are going wrong. So we'll discuss that in a little bit. But let's talk about what can go wrong with the bones. What are the bony issues that we have? The first is that the shape of the bone might not form correctly. So this is something during development of your knee that might go wrong. So we'll discuss some of those. Bony changes. This is once you're in adulthood, the bone has formed correctly, but then it starts to degenerate. So we'll talk about those. And then lastly, if you have a big enough trauma, you can actually break the bone as well. So if we start with the bony shape, this is what an x-ray of somebody around the age of 2 looks like. So if we look at the legs, you can see on this normal one on the left, you know, they're still pretty well defined. This isn't the kneecap. This is just part of the bony growth that we would expect. The rest of the knee is there. It's just cartilage, right? The x-ray is going right through it. So this is all that's calcified by the age of around 2, okay? But if we look at some conditions like rickets on the right here, we can see that there's starting to become changes already, right? So that knee's not forming quite right. You can see almost this fuzziness at the border. So that's not typically how we would like to see the knee develop. And then you can also see that we have this rather aggressive bowing of the leg, right? So you can see that the bones are starting to shift in shape as well. So rickets is caused by a lack of vitamin D. So typically this is maybe the mother is lacking enough vitamin D in the breast milk, maybe the formula, they're not getting enough. Whatever the cause, vitamin D is really helpful in the absorption of calcium. And calcium is critical for bone growth, right? So if we're not getting enough vitamin D, then the bones might not form correctly, and you might get a misshapen knee, for instance, okay? Here we have a different condition. So this is called Osgood-Schlatters. So this is a condition that affects the front of the knee. And on the left, again, a nice, clean, normal x-ray, nice, smooth lines. But if we look over on the right, we can immediately see that there's something, it's not right. So again, you can see these wispy-like bits of bone that are hanging off. You can even see that there's gaps behind. So what happened here? Well, the quadriceps tendon, what I was talking about, it connects into the kneecap and the kneecap into the tibia. So what's happened is when the bone was developing in this individual, they were constantly tensioning and tensioning, and they got, basically they avulsed, they pulled part of the bone off. So you can see that it's been pulled away. It's recalcified now in their later adulthood. But this is something you'd see probably in anywhere from kind of 10 years to maybe 15 years of age with really bad pain just below their knee. That's what they would be experiencing. Typically it's like from a repetitive strain, so the suggestion is to reduce whatever sport or activity that they're doing that is overdoing it. And one of the other interesting things that we can see by looking at the x-ray is if we look at the normal one, if I outline it, you can see this like thin little strip. It's slightly more opaque than the surrounding tissue. And if I remove the dotted line, you can see it now, right? So it runs right along and it connects into the shin. That's what it should look like. If we look at the person with Osgood-Schlatters, you can see, look how big it is, right? And it runs all the way down onto this entire piece of bone that has been pulled away, right? So that's what happened, is too much pulling on this tendon while the bone was still growing, and it pulls it away. So this would become a permanent deformity. People would have quite a large kind of bony bump over top. And I do get adults that still come in and they overdid a workout at the gym. They had Osgood-Schlatters as a kid and it flares up again, right? Because it's a permanent shape change in the knee. Okay. So what about bony changes? So after the bone's already set, it shouldn't change anymore, but what if it starts to? Well, this could be something like osteoarthritis. This is a wear and tear of a joint. So this would look like cartilage breakdown, which you can see on this image here, right? It should be a nice, smooth, uniform surface for the joints to glide. And this would be kind of a mild amount, but it's starting to break up and you're losing some of that thickness and smoothness. Underneath this can start to trigger bony changes where you get basically like bony bumps and bone spurs that start to grow out of it. And then you can get loss of joint space. So remember how I was talking about that nice even distribution of that gap we would expect to see in an x-ray? You can start to lose that. So in this individual, it's quite severe, but you can see basically the bone is now touching both sides. And they have other bony changes, right? You get this kind of growth out onto the side. You can even see a little bit of a bone spur forming on the outside here. And you're going to get all sorts of symptoms from this. This could be stiffness because the bones are starting to fuse or at least approximate together. You're going to get pain, swelling of the joint, and you might even get loss of function, right? So if you're trying to bend your knee, but it's just bone hitting bone, you won't get the same amount of movement anymore. So that's what can happen with bony changes. In terms of conservative care, which is what chiropractors and physios at AST are providing, what can we do about it? Well, the first thing we'd like to do is just identify what is happening, right? What tissue, what structure, what bone is involved in this. And then as a chiropractor, one of our specialties is adjustments. So that's when we do kind of a rapid movement of a joint to help gap and provide more joint space and allow an increase of movement to that area. right? So probably more in a mildly arthritic knee, that's when we would be doing adjustments. As it gets more severe, that might there might be too much inflammation in there already, so we might consider something like immobilization, where we slowly work through the joint in different directions to help improve the range of motion and try to restore what amount that joint still has left. Okay. Third, we want to relieve pain, so this can be done through so many different ways. Adjustments as well can help reduce pain, but MRT and ART, which are soft tissue techniques where we work through very specific groups of muscles to help release tension and reduce pain as well. We have all sorts of modalities available at our clinics, so this could be anything from laser to ultrasound, which can help improve healing times as well, and I'll touch on those a bit later. We want to address your posture and your biomechanics. So if it's particularly pervasive in one knee, you might be compensating on the other side. So how can we address that? You know, are there certain muscles that we have to strengthen on one side versus the other? Are there certain positions that we shouldn't be putting you in anymore? Maybe kneeling down to do your gardening and stuff is not going to be helpful for you anymore. Maybe we should bring that up onto a counter if possible, stuff like that. And then we want to manage symptoms. So as osteoarthritis gets worse, I have a couple of these cases right now where people are in line for knee replacements, and it can take over a year to get. And they just need help getting through the day-to-day. So we help manage the symptoms until they can get a full knee replacement. So I'm going to show you what those look like. So in cases where it's more severe, what they'll go do is they'll take part of that bone off that's beginning to change and is no longer effective at its job. And they'll put in basically these new ones. And you can see they implant right in, and the joint spacing is back, and they glide right on each other again. So this is definitely an option in those really severe cases. But again, because of the wait lists, people often seek conservative care to try A, to prevent this, or B, to help them get through the surgery and do the post-rehab as well. Okay. Other issues that happen with bone is breakage. So this is called a tibia split fracture. And the way that this would occur is usually from a fall where you land on your knee, or even you land directly on your heel, and that femur comes directly down and it presses directly into the tibia, and it splits a part of it off. So in this case, you'll pretty much know immediately that you have a fracture. It's going to hurt a whole heck of a lot. And if you took an x-ray, it's not as clear as the image here, but the x-ray, you can see there's like this lucency, this gap right in here. It's no longer these nice smooth lines. And that means that section has basically fractured off. When this is the case, conservative care, we can identify it. If it's not quite as severe as this and you're not entirely sure, we can definitely identify these. But when it comes to repair, you're really looking at surgery, and that's basically going to be screws throughout the bone and with a plate to hold everything in place, right? Okay, that's a lot about bones. Let's get into ligaments. Ligaments are that strong white fascial tissue that is basically the glue, the tape that's holding all of your joints in place. And they play a really, really important role. And we're going to go more in depth in it today than any of the other lectures. So the first four ligaments I want you to know about are the big four in the knee. So if we look on the diagram on the right, we have ACL, which stands for anterior cruciate ligament, and we have PCL for the posterior cruciate ligament. Now, these are actually internal to the knee, so they are within the joint capsule. So I can't actually press on them and feel them if you came into the office, but I still have ways of testing them because I know what their function should be. So the ACL in the front there, that's going to prevent that anterior slide motion, right? So if you imagine your knee is stacked on top of each other, right? It shouldn't be sliding back and forth like this. It's only supposed to hinge, right? And the ACL and the PCL prevent this motion. Okay, so if I tested that and it was really loose, then I would have an idea of which one of these was either partially or completely torn. And then we can have a talk about, how would we rehab this, or is this possibly, to the point of surgery. And then the other thing you'll notice is that they almost make this X-like pattern, right? So they're kind of crossing over each other. And what this provides is additional stability in preventing rotation of the knee. If you think about it and you plant your knee, it's really not supposed to rotate a whole lot. That would bring the joint out of place and could cause all sorts of injury. So the way that this has evolved is to provide this kind of X-like structure to prevent rotation. Additionally, we have the MCL, which is medial collateral ligament, and it's mirrored on the opposite side by the LCL. So that's the lateral collateral ligament. Now, what these provide is stability from that side to side motion. So again, if you guys can see my video, it's not supposed to rock back and forth. So that's what these ones do. They prevent that motion, okay? So each one of these is really critical in preventing the motions we do not want in the knee. And if you have an injury to one of them, we want to make sure that we stabilize the knee in such a way that it is securing it to prevent these aberrant motions from occurring, okay? So each one of them can get injured separately and even together. So the PCL injury, you can see here, these are examples of full tears. But that's going to allow the joint to slide slightly more posterior. And then on the right here, we have the ACL, the front one, when that one's ruptured, and that's going to allow the knee to slightly slide forward, right? So what we want to do is try to prevent these from happening. And if this does occur and they're full tears like this, you're probably considering surgery if you're an athlete, especially if you're trying to get back into sports right away. But if this was kind of a tear that happened and you're not an athlete, this is something we can try to deal with, especially if it's a partial tear, try to rehab it and allow it to basically firm up again so that you're not re-injuring the area. For those external ligaments, the MCL and the LCL, they can also get injured, and how they get damaged is usually through a force through the side of the knee. So on the left, we have what a normal knee should look like. And then on the center image here, we have the MCL injury. So what happens is you get a force from the outside of the leg, pushing it inwards, okay? And what happens there is the force expands the inner portion of the knee enough that the MCL ruptures. Okay, and if the force is really extreme, some of those other ligaments on the inside, like the ACL, might rupture as well. Okay, same happens for the LCL, except now the force is coming from the inner knee. So perhaps, like a fight, like MMA, somebody kicks the inside of your knee, or you take a puck or a soccer ball to the inside and it expands the outside and it ruptures. Okay, again, if the force is enough, you can even rupture those internal ligaments as well. But what else I wanted you to notice is where I put these red down arrows is those sides are getting approximated, okay? And what can happen is the femur's hitting that cartilage, the meniscus we were talking about, and it can injure it as well. So you can kind of get multiple areas. They can be isolated, but they can also come in pairs. So there's a pretty famous one. It's called the unhappy triad because, well, it's pretty self-explanatory. You don't want to get this, right? And it's three major injuries. You get the ACL rupture, you get the MCL rupture, and then you also get meniscus damage, which is that disc, again, right in the middle there, okay? This is typically happening if the leg is planted and then there's a force to the knee, because then the foot can't move out of the way. You get this kind of rotational inwards collapse, and then these structures begin to tear. So in that case, when there's multiple tears and injuries, it will be a longer rehabilitation process. So let's talk a little bit about why ligament injuries are so important. There was a really good paper written by Roshauser and Aaron Dolan that discusses this, and I'm just going to kind of read verbatim a really good quote from it. Ligament injuries create disruption in the balance between joint mobility and joint stability, which can lead to abnormal transmission of forces throughout the joint, resulting in damage to other structures in and around the joint. So what they're saying here is that a ligament is really important in providing enough stability and allowing normal motion in a joint. So if it gets disrupted, not only is it going to be damaged, the ligament itself, but the surrounding structures. So they go on to say that this can even lead to osteoarthritis, right? That condition we were talking about earlier, where the wear and tear of the joint, and even the loss of that joint space, okay? So let's talk about, okay, now once it's injured, how can we heal it? Well, the body has a process that it goes through already, and knowing about this process helps us guide our treatment. So the first, it's split into 3 phases. The first is called the acute inflammatory phase. And as you can see on the graph, this is only lasting a couple days, typically 48 to 72 hours, okay? And I want to go on a bit of a tangent here that inflammation gets a really bad rep. It's something that is almost always associated with something that's bad or negative. And we typically just try to get rid of it as soon as possible. But my argument here is that it really has a role to play. And the role is this. When a tissue gets damaged and there's like a rupture in it, it releases a bunch of chemicals, right, that trigger a cascade of inflammation. So it basically slowly sends out from the source a diffuse range of chemical markers that trigger all sorts of interactions in the tissue. And one of those roles is to bring the healing cells to the source. So once they start getting the signal, they keep following it until they hit the source. And once those immune cells and those healing and the repair cells reach that area, that's when phase 2 starts. And that's the regenerative and repair phase. So those immune cells are starting to release markers, as well as some of the repair cells that actually begin the healing of the tissue. And this is when we hit this middle phase. So this is going into weeks, into sometimes months. And we see quite an increase in strength as it begins to repair. And this is kind of, I like to think of the analogy of like there's a hole in the side of a boat, right? At first, you have to go get everybody, to come repair it. That's the inflammatory phase, right? Phase 1. Phase 2 is once you're there, you have to start repairing it. And when water's leaking in, you do anything, right? You slap any board on there that you can to just stop it from leaking. And that's the regenerative phase. And phase 3 is, okay, now the leak is stopped, but now we want to make this look better, right? We patched it all over the place. It looks terrible. Let's, refine it and try to make it look like there was never an injury here in the first place. The only issue with that is what I want to draw your attention to on the graph. Injured tissue never reaches the same strength as healthy tissue. Unfortunately, our bodies just can't build quite the same tissue as the original, and it's never going to be quite as strong, okay? And what this means, or if I kind of summarize what the paper brings up, it's this. It's that ligaments heal through a series of cellular events, right? Phase 1, 2, and 3. And that can take months to years, right? That last phase of remodeling, for tissue, it can last anywhere from a year to up to 2 years if you're pushing it. And many of the ligaments do not regain their normal strength. And what the authors also mention is that laxity in those ligaments can lead to joint instability, chronic pain, diminished function, and even osteoarthritis, right? So it's really important that we take the time to try to heal these ligaments correctly the first time. Ideally, we would try to prevent them, right? Because healthy tissue is always the most strong. But if there is an injury, we want to get kind of early in on that process so that we can start that healing to try to get it to the maximum strength allowed. So what do they tell us about what we should do? Well, they mention some things to avoid and some things for us to do. The first thing they say is avoid rest and immobilization. And one of the studies that they were pulling from is this where this graph is from. And what they did is they looked at dogs and they ruptured one of the tendons in their knee. And Some of the dogs they put in a cast so they couldn't move. And some of the dogs, they just let them do whatever they wanted. And then the last group, the trained dogs, they try to encourage exercise. And what they found is that on this axis here where it says the fiber bundles, that's basically equivalent to the strength. They found that the dogs that moved the most and exercised actually had the strongest ligaments. The normal group was slightly less, and then those that rested had the worst strength. So that's why they encourage mobilization and exercise in a joint. The other thing they told us to avoid was NSAIDs, which is non-steroidal anti-inflammatory drugs. Some common ones, for example, would be, well, like Advil. That's a really common one. But you can also just, if you just type in your medication into Google, you could probably see if one of them is an Advil, if one of them is an NSAID as well. What NSAIDs do is they reduce the inflammatory response. Remember when I was talking about the phases, and phase 1 is that acute inflammatory response that brings all of those healing cells to the injury. It's going to knock that down. Same with corticosteroid injections. It's really great at bringing that inflammation down, which is great for relieving pain and discomfort for us. But in the long run, we're kind of hurting ourselves because we're not allowing the tissue to heal to its full strength. And then so things that they do recommend are, again, that mobilization and the exercise to help improve the strength of the joint. And then something else called joint loading. The idea here is, when I was talking about when you're filling the hole and you're slapping all that stuff on top, it's not in any particular direction, right? You're putting it down in any direction to stop the water from leaking in. But when you go back, you want to, align all the boards with the rest of them. You want it all to be in a nice straight line. Well, the way the body can tell that is if you stress a joint. So if you were to load it in the fashion that it should be, for example, if you were to do, like a jump on your knee, that would load, the tendon in the direction that it should. The body can sense that, and then it realigns the fibers in the correct direction. And that actually increases the strength of the tendon and ligaments as well. Okay, that was a lot on ligaments, so thank you for bearing with me on that. We're going to move on to muscles. So this is the third layer I want to discuss. I'm going to simplify it a bit, and we're just going to break it down into two major groups. So the first group is that flexes or bends the knee, and that's the hamstring muscles. Okay, so these are on the back of your thigh, and then we have the opposite of that, those that straighten your leg. So that would be called extension, and this is predominantly performed by your quadriceps on the front of your thigh. Okay, so I want to describe how these work so that it makes sense of how we're moving a joint and why these muscles are so important. So here the hamstrings are located on the back, and in this cross diagram, I'm going to highlight them in green, right? So the hamstring's coming all the way down, it's connecting into the back of your tibia. And if we imagine that it contracts, it's going to shorten and pull up. And now, due to the shape of the joint and all of those ligaments holding it in place, the only way the tibia can now move is backwards, right? So this is, if you're loading up to, kick a soccer ball, this is what's loading the leg back. So if I were to show, a video of this, this is exactly what it would look like. So these back here are the hamstrings, and you can see that as that muscle shortens up, it gets a little bit bulkier. It's almost like it's swelling, right? And what that's doing is it's bringing your heel towards your butt. Okay, so it's getting that leg into flexion. Okay, and if we look at the opposite side, we have the quad muscles, right? The quadratus. And this is a series of 4 muscles on the top of the thigh, and they do the opposite motion, but slightly differently. So if I highlight them here, the quad comes down, but instead of directly going into the tibia, the first thing it does is it connects into your kneecap, the patella. And then the patella then interacts with your tibia. So if the quad contracts, it's going to pull up on the kneecap. The kneecap in turn pulls up on the tibia. And again, because of the shape of that joint and the way the ligaments are designed, it only has one direction to go, forwards. Okay, so that's going to straighten the leg out. So you can see if we start in a bent position, here the quad contracts, you can see it getting shorter and smaller, and that brings your leg forward. That's how it kicks, okay? So these muscles are really important for anything from walking, running, all sorts of sports, right? Essential in our everyday lives. So if they get injured, what can we do to treat them? Well, again, the first thing, as always, we have to identify which muscle it is, okay? There's more than even the ones that I talked about, but as chiropractors and physiotherapists, we all can, identify which muscle is the issue. From there, we want to address your mechanics, right? So how is the knee moving with this injury? Is there an alteration? Is the knee collapsing towards the inside, or is it pressing out? Has there been a substantial change? Because that's definitely something we'll have to address. Maybe we have to make one side stronger to compensate. Other things we can do are the soft tissue release techniques that I talked about before. So that's the MRT and the ART, which our clinic specializes in. And these techniques work to alleviate muscle tension by basically working out some of the adhesions that occur during joint injuries. Okay, it also works the joint through its ranges of motion, so it can help the joint in that way. We can do some of the modalities. So I mentioned a few of these before, but laser, IFC stands for interferential current. So that's the image on the bottom there where you get those pads that are placed over a muscle and cause little mini firings of the muscle. Ultrasound provides nice deep heat if the muscle is not superficial, we can't really get to it. Ultrasound can be a great option. And then Game Ready is a way to help reduce inflammation without providing an NSAID, right? So this is kind of like an ice pack that can go over top. It can help relieve some of that acute pain that people are experiencing without basically stopping the inflammatory reactions from occurring. And then also we want to rehabilitate and strengthen, right? So as you start to improve, we want to make sure that the tendons and the muscles are improving in the right way. And then we want to strengthen anything because, again, the tissue never fully returns to its original strength. So we want to make sure that we strengthen it enough that the injury doesn't reoccur. So let's talk a little bit about prevention and home care. The first thing I'd say is lower body posture is really important. It's quite a big topic. I covered it in the SI lecture, so I would encourage people to go back and watch that if you need. But the premise is this, is the way the pelvis is positioned can be really important for the muscles above and below. And particularly for the knee, we're concerned about the ones below. So again, the hamstring and the quadratus, those both connect into the pelvis. So where we're positioning the pelvis can be really important in how our knee functions. The common saying of everything is connected really stands true for the body. Pelvic posture, important for our knees. The other thing I'd like to do is address daily habits. So, especially these days, lots and lots of sitting is happening. I would encourage people to take micro breaks. Every 20 to 30 minutes, there's basically a release of strength in a muscle. We call it hysteresis. It can't hold the same position for too long. So taking a micro break where you stand up, walk around, whether it's around the office or you go to the kitchen and come back, this can help break that cycle so that the muscles can hold nice and strong during whatever task you're doing. Postural changes can be really helpful as well. So if you have a standing desk, please do use them. Kind of alternating back and forth can be helpful. Standing all day for 8 hours is probably better, but not the best for you either, right? Let's alternate between the two. And other things I'd mention are some people like to really, sit on their foot. Or they kind of like lean over to the side. I would just kind of address your posture. We don't want to sitting on the foot can be really hard on the knee. There's a lot of side forces that go through there. And as I discussed earlier, the knee is not really meant to move in those side directions. So trying to put your feet flat on the floor is probably the best option for you. If you really need to sit on your knee, try to limit the amount of time and try to switch back and forth between the knees so it's not too long on one. Other things I would encourage are stretching. I'm going to go over some of those at the end of the slides. And then we also want to address muscle imbalances. So if you've come in and we've identified a muscle imbalance, we'll give you strengthening exercises to help address that, right? So sometimes I see this where people get a cast, they broke, an ankle or something, they have a cast, and then when the cast comes off, they haven't used it in a while, and that side is weaker than the other. There's an imbalance there that we want to address. And then the last thing I wanted to mention is seeking treatment early. Again, this comes back to that graph I was talking about. If you've had an injury, it's been lingering for a year, you're kind of approaching the end of that remodeling stage. There's not a whole lot more to be done. We encourage you to come in early enough that we can make a substantial difference. Now, if you are coming in that year to 2 years after an injury, we do see it, and we can still help. There's things we can do to help try to revert that process back to the remodeling repair stage, stuff like shockwave and different instrument assisted techniques that we perform. But really, you want to improve it the most the first time round, right? You want to get it as close to healthy tissue as you can. So I do encourage seeking treatment early on. So I wanted to cover a couple stretches for everybody that you can do at home. I worked with Olivia Tomlins, who's our physiotherapist, to just provide some kind of nice, well-rounded ones. The first one is a prone quad stretch. Now, I recommend doing it prone if you can. You can do this one standing, but people tend to cheat when they're standing. So I like to get people to lie down for it. You want to keep your knees together. Don't let the knees separate. And if you can't quite reach back to grab your foot, you can always just wrap a towel or a belt or something around it and then use that to get the motion that you need. You want to hold this stretch for about a minute per side, maybe 2 if you're able to. I would recommend actually trying to get 2 minutes per side. So take about 4 minutes. It doesn't need to be 2 minutes in a row. It could be 1 in the morning, 1 in the evening. That's fine too. Okay. I will show you the standing one here. The reason I recommend, let me just move this just a bit. The reason I recommend not doing it standing is people tend to cheat where they kind of lean forward or they tilt at the pelvis here, right? You're not getting a whole lot of stretch. So try to go nice and straight as if you were on the floor and then pull it in. If you want more, you can push the hip forward and really feel it. You should feel that through the front of the quad into the base close to the knee, right where that's attaching, okay? And then the next one is a supine hamstring stretch. So this is getting that back side of the thigh. And this is actually a great stretch because it can really vary depending on your flexibility, okay? So what you want to do is kind of scooch up towards a wall, a corner, and place one leg heel up. The closer you get to the wall, the more and more stretch you'll feel. And we can actually make this active as well. So I'll show you, might be a little hard, but let's see. I'll try to show you how to make this one active, okay? So if you get close to a wall, you can put your foot up against it, right? And then if you feel a stretch here already, all you have to do is just flex the knee, right? Or extend the knee, sorry. So you're pushing it closer to the wall, and that's going to add more stretch. And if you need even more, you just get closer, and then you can push in and push in. You'll feel that right in the back. So that's a nice way to get the hamstrings going. And again, for this one, you're trying to get a goal of 2 minutes on each side per day. So a minute in the morning, minute in the evening. And the next one is called a gastrocsoleus stretch. Now, we haven't covered this muscle yet. It does go into the knee, but it also goes into the ankle. So I'll be talking a bit more about it in the next lecture. But how to stretch it is, there's 2 different ways. The one in this image is my personal favorite. I prefer because it also kind of stretches the bottom of your foot. The goal here is to place your foot with the toes high enough on the wall that when you lean in, you get a pull in the backside, okay? The backside of the calf. And you'll also get a bit of a stretch on the bottom of your foot, okay? The alternative, if you prefer, is to step back and then lean in. And now it's this leg that's getting the stretch right here. So you can lean into the wall that way. So that's another option for you. Okay, so that's 3 basic stretches. Again, each one we're looking for roughly 2 minutes. per side, okay, in a day. And I think you would start to see some improvement. And if you want exercises or anything like that, feel free to reach out to us. I'd be happy to take anybody on as a patient at this time as well. So that pretty much covers everything for the knee. I hope that you guys enjoyed it. And next lecture will be on the ankle as well as the foot. So that'll be next month. And again, here are the links. So if you wanted to watch any of the previous one, you can go to the AST YouTube. And if you need to call in the clinic for anything at all, you can always reach us here. I'm at the Westman Village location, and that's the number right there. So if there are any questions, please let me know.
Wonderful. I think yes, I did. I unmuted myself. Wonderful. Thank you so much for all of that information. This one is a little personal on my side as I'm repairing a knee injury that I left far too long and continued to ski on. So every time you may have seen me cringe every time I thought of
Yeah.
the pain that some of these injuries would have. I have a question when you explained those stretches. Is there, can you end up overstretching, or is it just something that you go to a certain point?
Yes,
That you
you
feel a stretch for?
you can overstretch. So that's a really good question. In fact, that paper even talks about it. If you overstretch too much, you can actually weaken the ligaments themselves. So that's not something we want to do. So keeping it to around the 2-minute range would be a good idea. And also when you're doing them, I wouldn't, don't push into pain. If you're pushing into pain, you're probably stretching them too far, right? So you just want enough that you can feel it there, but it's not hurting. And that should be, that paired with a time limit, that should be enough to prevent overstretching.
Okay, thank you for that. Are there any questions from our listeners at all? I'll let them come in if needed. While we're waiting for the questions, Dr. Evan has one more webinar in the lower extremity series, which he's put together, and that's going to be coming up in December. He had just mentioned. The date isn't coming to me on the top of my head, but it will be coming up in the newsletter, which will be coming out the first Friday of December. I'm not seeing any questions. Be sure to work on strengthening and stretching that knee, and be sure to make an appointment with Dr. Evan or any of the practitioners at Active Sports Therapy if you need assistance or have questions of pain that you may have, even if it's mild. Don't go skiing a full season on Advil and wonder if you're going to get better.
Well, now you know about Advil.
Well, yes, I tend to. Yeah, that was a terrible idea. I think that's all for now. Thank you for this wonderful webinar, and thank everybody for their time, for coming. We always appreciate seeing your smiling faces and seeing you guys listen wherever you may be. Oh, there is something that came in. Oh, do cortisone shots cause any damage?
Okay, so cortisone shots, like I was saying, they help reduce the inflammation. So the only, I would say this, they're not causing direct damage, okay? What cortisone is really typically used for is to knock out the pain, and it does a fantastic job at that. So if somebody does have really bad knee pain, and it's to the point where, you know, they can't walk, cortisone injections would be a wonderful idea, because you've already lost function due to pain, right? And the cortisone can help knock that pain out so that you can get some function back. But if it's something that's manageable, then what's going to happen is it's going to reduce the amount of healing cells to that area, and it can weaken that long-term recovery. So we're talking kind of a year down the road, that might be weaker because of the cortisone. So in that way, it's kind of indirectly damaging the amount of strength you could have. But directly itself, it's not injuring the tissue, no.
Wonderful. And I don't see any further questions, so I think we can call it a night.
Perfect.
Thank you so much once again,
Yeah.
Dr. Evan, and thanks
Thank
everyone
you.
for joining. We appreciate it. Bye now.